present Mr. VS, a 29-year-old male who was admitted in PGI in September 9, 2022. He died on 17th September 2022. He was admitted under nephrology services under the care of Professor Navneet Sharma and I will discuss in the clinical part. The pathology will be discussed by Dr. Edwin and the radiology will be discussed by Professor Kumar. This patient had a significant background history. He had 3 admissions, 2 in GMCH 32. The clinical details courtesy of Professor Sanjay Deepru, who is head of Department of Medicine at GMCH 32. He was admitted in GMCH for 2 times, first in November 2021 and second time in April 2022. His presenting complaints at GMCH were NSRP and gradually progressing soft tissue threat, which is MRC 350 for 6 months. He had a repeated history of childhood infections with fever, cough and expectoration. And I called up the family and I talked to the brother. He says that he used to have these recurrent chest infections since the age of 5 years. He had COVID-19 infection in 2021. He was treated conservatively at home. To diagnose having sputum positive tuberculosis, he had undergone a 6 months ATP from September to March 2022. Examination at GMCH revealed grade 2 clubbing. There was bilateral periodema, facial purplish, bilateral crepes. He was hypoxic during the second admission at GMCH, but surprisingly there was no history of decreased urine output and he had normal creatinine levels at GMCH. .4 grams. His ultrasound KOB at GMCH revealed bilateral renal medical disease and bulky kidneys. He had leukocytosis, his creatinine and his kidney function tests were nearly normal. He had mild transaminitis. He had a deranged lipid profile. He had iron deficiency. His triple viral screen was negative there. And his COVID PCR in both these admissions was negative. He underwent a left kidney biopsy on 6th of April. While the IgG was increased, IgM was also increased. His CPNAC was 19, his procalcitonin was 32.9, and his workup for primary probably underlying geography, that is Rho and La, was negative. Topical fever workup this time was negative. COVID RT-PCR was again negative. Triple virus skin was also negative. Urine routine again showed 3+ albumin. There was no RBCs of pus cells. Culture, urine culture and blood culture was sterile. Sputum culture showed E. coli was sent on the next day of admission. While ET aspirate was negative both all for AFB, fungus and bacteria. ECG showed synergism and co-regulation of R wave. The ultrasound of the upper limb showed a right axillary breakdown. He had shrunken kidneys and they were bilateral raised renal ecogenicity. In the ultrasound abdomen, the bowel loops could be visualized with internal content showing sluggish peristalsis, suggestive of small bowel obstruction. He underwent 3 CTs, 1 at GMCH and 2 at PGI, would be discussed by Professor Anupam Lal.
Good morning. This patient has a chest X-ray, abdominal X-ray and 3 sets of HRCT which were done in April, August and September respectively. The X-ray shows basically there's a ring-like shadows in the left lower zone and mid zone and right paracardiac region which are suggestive of bronchiectasis. There are multiple small nodular densities seen in both lungs, which which will be seen better in the CT images. So basically, there are bronchiectasis and multiple nodular densities in both the lungs. The abdominal X-ray shows mildly dilated jejunal loops in the center of the abdomen, thereby suggesting that there is fluid in the abdomen. So there is ascites and mildly dilated jejunal loops. And this is the first CT scanogram, which shows confirms this ring-like shadows in right paracardiac and left lower zone. And one can see in these mediastinal windows that the thyroid and trachea and bronchi are normal. There are some subcentimetric lymph nodes in the mediastinum in pretracheal and subcarinal location. And you can see this cystic and cylindrical bronchiectatic changes involving the right lower lobe, right middle lobe, and the lingular segment here. In the abdominal section, this is non-contrast CT, so not much can be said about it, but the pancreas looks normal. The kidney appears mildly enlarged, although the upper sections are all only there. And this is the lung window section of in this first set of CT images. One can see that there are some fibrotic changes in upper zones, upper apical segments of upper lobes, and this cylindrical and cystic bronchiectatic changes in both the lungs. The bronchi at places appear thickened, and there is some retained fluid within the dilated bronchi. And you can see the multiple nodular densities in both the lungs, some of which are centrilobular, some of them are random nodules. And this is the second set of CT, not much difference than the previous CT, but here what we can see is that bilateral pleural effusion have appeared. And these are coronal sections to show that the bronchiectatic changes are extensive in the left lower lobe with nearly complete destruction of the left lower lobe. And one can see here the lower lobe is completely destroyed with cystic and cylindrical bronchiectatic changes, some retained fluid with air fluid levels, and the right middle lobe is also completely destroyed. There are other fibrotic changes and multiple small nodular densities in both the lungs. And this is the third CT set images, which shows the disease appears slightly progressed here with bronchiectasis. And one can see that there is appearance of this soft tissue density in the right lung apex, which can be seen clearly here, which was not there in the previous CT done approximately 5 months back. There is the appearance of a small cavitary lesion here. This is rapid appearance of this lobulated soft tissue mass probably suggests a benign pathology, not a malignant pathology. Could be a cavitary lesion and intracavitary hemorrhage or a fungal ball, but appears to be benign. Rest of the findings are nearly the same, and you can see the multiple centrilobular nodules, which are in having a tree and bud appearance. So concluding, there are cylindrical and cystic bronchiectatic changes in both the lungs, which are more marked in the left lower lobe and the right middle lobe, with nearly complete destruction of these lobes. There are focal fibrotic changes in lungs, a small cavitary lesion in the right lung apex, and multiple centrilobular nodules, which can be because of infection, and most common infection which we see with cavitary lesions is tuberculosis. Otherwise, this can also be retained secretions or some unusual infections. There are bilateral pleural effusions and ascites, and there is a right upper lobe mass-like lesion, which are likely an inflammatory mass. I'm not sure what it is because this is non-contrast CT, and not much can be said, but appears to be an inflammatory lesion, and a fungal wall within a cavity lesion cannot be excluded. Thank you.
Thank you, sir. So we have a 20-year-old male, a past history of childhood history of cystic bronchiectasis, nephrotic range proteinuria, kidney proven renal amyloidosis, recent worsening of kidney functions of maintenance hemodialysis. He is referred to PGI with complaints of loose stools and worsening shortness of breath. In 2021, he had pulmonary pox. He was treated with ATT. He also had COVID-19 infection. Admission in EMO3 was hypoxic and was provided oxygen supplementation. Hyperkalemia was managed with medical measures followed by a session of hemodialysis. He was initiated with intravenous fluids, antibiotics in form of piperacillin tazobactam, and was shifted to EM ward. Extensive investigations were done for the etiology, but certain worsening were conducted. For the next 24 hours, his condition deteriorated with worsening hypoxia, hypercarbon, needing mechanical ventilation. Post-intubation, he developed hypotension, received IV fluids and inotropes. Antibiotics were changed to renal modified dose of intravenous colistin and teicoplanin based on culture sensitivity. Hemodialysis was continued with PRBC's transfusions for anemia. It was DVT of right upper limb treated with therapeutic doses of heparin. Shock continued to worsen, vasopressor requirement increased, he developed paralytic ileus and persistent bursting of sensorium. Various imaging modalities were planned but could not be done because the patient was hemodynamically unstable. Pre-terminally, he had hypoglycemic records for which dextrose infusion was started. Patient suffered a cardiac arrest on 17th September. CPR was done according to ACLS guidelines. Patient could not be revived and was declared dead at 6:50 p.m. So, unit's diagnosis was childhood or onset cystic bronchiectasis, nephrotic range proteinuria, kidney biopsy proven renal amyloidosis, CKD stage 4 on maintenance hemodialysis with acute deterioration, right axillary and brachial vein thrombosis, acute bacterial pneumonia, and refractory septic shock. Coming to my discussion, so we have database who had we have a young male with repeated childhood respiratory infections, probably by starting at 5 years of age. He had cough with copious expectoration for 2 years, gradually worsening shortness of breath and hypoxia since worsening hypoxia since April 2022. There was clubbing and bilateral crepes. There was anasarca with nephrotic range proteinuria. Kidney biopsy had amyloidosis. There was rapidly worsening of renal dysfunction within 4 months, and ultrasound which initially showed bulky kidneys later on showed shrunken kidneys. Independent loose stools with hematochezia, past history of tuberculosis and COVID-19 infection. In the present admission, he had acute deterioration. He had anemia, hypoalbuminemia, and proteinuria, deranged lipid profile, and bilateral shrunken kidneys. There was acute respiratory distress requiring ventilation. As told by Professor Anupam Lal, he had a mass-like lesion. There was cystic bronchiectasis. There was bilateral pleural effusion, and there were bilateral central nodules with tree and bud-like appearance, and there was small fibrous cavitated lesion on the right apex. This developed over the last 4 months only. He had neutrophilic leukocytosis, thrombocytosis initially, and he had high procalcitonin and CRP, and he had E. coli sepsis. And pre-terminally, he had refractory shock, and he had a right axillary brachial vein thrombosis, probably related to central line. So, one thing is for sure that patient had a long background history, so which included respiratory and involvement of the kidney. So he had bronchiectasis for sure, and he followed the classical bronchiectasis cycle, which was described by Cole. He said that there's inflammation, there's some airway remodeling, there's mucus accumulation, there's infection, and this goes on and on, the subsequent development of bronchiectasis. If you go to the etiology of bronchiectasis, in the West, one of the most common causes is cystic fibrosis, but data from the Indian registry shows that tuberculosis is the most common cause of bronchiectasis in the Indian subset. But in our index patient, the tuberculosis was only 1 year of back only. So an underlying predisposing has to be there. There was absence of asthma, there was no eosinophilia, and there was proximal, there was absence of there was no central bronchiectasis, so I can rule out ABPA. With the absence of history, I can probably rule out these conditions also. Absence of rash, absence of joint pains, I can rule out these connected disorders. The triple virus screen was negative, so I can rule out HIV. Since the onset is probably during childhood, so we have to consider, because this is as per the etiologies of bronchiectasis, but with the absence of history, I can also negate these things. So coming back, we have 3 major categories, that is mucociliary dysfunction, cystic fibrosis, PIDs, and so I'll be discussing a little bit about these. Primary ciliary dyskinesias, it's autosomal recessive. The clinical diagnosis is 2 out of 4 are patient fulfilled, that is cough and bronchiectasis. Diagnosis generally confirmed by measurement of nasal nitroxide, and confirmation is bimolecular, that is demonstration of mutations. The classical mutation is SCNN1A and the DNA I1 genes. This was a 13-year-old female who had bronchiectasis, was reported from Department of Pulmonary Medicine, had a PCD, but also had a sweat chloride test positive. The second differential, which is quite common cause, is in the Western population of bronchiectasis, is cystic fibrosis. Again, it's an autosomal recessive multisystem disorder, leads to manifests a chronic lung disease in children, exocrine pancreatitis deficiency, and the defect in the CFTR gene, which actually regulates the epithelial chloride channel, and is corrected by salty sweat and a horde of symptoms. Our patient had repeated respiratory infections, bronchiectasis, and clubbing. Well, if it is recognized early in infancy and childhood, but if undiagnosed, it leads to a horde of symptoms when it progresses to adulthood or adolescent age. Our patient had respiratory failure, distal intestinal obstruction, and renal failure. Renal failure, I'll be discussing in the subsequent slides as part of cystic fibrosis is very rare. It's one of the least known complications of cystic fibrosis. So this makes me feel that the etiology of bronchiectasis is probably not related to cystic fibrosis or the ciliary dysfunction, and because cystic fibrosis, the bronchiectasis is generally in the upper lobes, while in the non-cystic fibrosis, bronchiectasis is generally in the lower and middle lobe, which was present in our patient. We did not isolate the typical organisms associated with cystic fibrosis, that is Pseudomonas and Haemophilus, though we had isolated Staphylococcus. We did have distal intestinal obstruction and anemia. And as I've already said, renal amyloidosis is more common in non-cystic bronchiectasis than in cystic fibrosis bronchiectasis. So non-cystic fibrosis bronchiectasis is more likely etiology in the index patient. PIDs, we had a near normal or a low normal immunoglobulin levels at admission. So antibody deficiencies are more or less ruled out, but with the absence of the lymphocyte subsets which are not done, and immunoglobulin subclass levels were not done, I cannot rule out a PID in our patient. The second important part was anasarca and amyloidosis, and most likely a patient had secondary amyloidosis. And etiology of amyloidosis, again, differences, if we, as a summary, it's a horde causes, a huge number of causes. Absence of rash, absence of joint pains or back pain, no fever, normal anti-rolla, normal pulses, no evidence of malignancy, no addictions, no skin lesions, no chronic ulcers, no bony lesions, HIV non-reactive, thin-built patient. So I can rule out these etiologies. Autoinflammatory disorders are nowadays considered very important etiologies, but the diagnosis generally confirmation by molecular. So probably in our patient probably had an underlying PID or autoinflammatory disease led to recurrent childhood respiratory infections, bronchiectasis, and amyloidosis. Cystic fibrosis amyloidosis is quite rare. Most common is the renal function dysfunctions are scheduled glomerulosclerosis, and tubular dysfunctions are more common. Well, some glomerular lesions like minimal disease and PGN have been described. So I would, in my patient, I would probably keep a non-cystic fibrosis primary cell disease etiology of amyloidosis is more likely in my patient. Patient had probably involvement of GIT. There was rapid deterioration, probably because of multiple causes, as I've already told. And amyloidosis predisposes to infection, and most common cause of death in these patients is sepsis and cardiac cause. So did my patient have reactivation of tuberculosis? Well, probably yes, because there was upper lobe cavity, there was a tree and bud appearance, there was intermittent hemoptysis, and there was small lymph nodes in the chest. But this tuberculosis was not the primary etiology of bronchiectasis, as it was a short duration. As already said by Professor Anupam Lal, that a right upper lobe mass most likely is a benign etiology. I would keep a possibility of fungal ball. Preterminally had hospital infections and refractory hypoxia and hypotension. So my final diagnosis is childhood onset cystic bronchiectasis. I would like to keep a non-cystic fibrosis or PCD etiology more than a PCD or a cystic fibrosis related. My possibilities would be an underlying autoinflammatory or PID. He had secondary amyloidosis with nephrotic range proteinuria, involvement of probably kidney, GI, cardiac, and blood vessels. He had CKD stage 4. He had right axillary and brachial vein thrombosis, most likely catheter-related. I would expect reactivation of pulmonary tuberculosis. Mass lesion is probably most likely a fungal ball. He had sepsis, MODS, and preterminal refractory shock.
Yeah. So the complete autopsy was performed in this 29-year-old male with the clinical diagnosis as discussed by Dr. Vikas sir. And the prosectors observed that the peritoneal cavity yielded 1.5 liter of straw colored fluid, whereas both the pleural cavity and pericardial cavity were within normal limit. So I will start with the kidneys. So both kidney weighs 450 grams, which is slightly heavy, and it is also, we can see it is slightly increased in size. The capsular surface is not smooth, and it shows scars and some nodularity. The cut surface shows distinct cortical medullary junction, and it has a waxy feel. However, there is no focal discrete lesion seen. On microscopy, we can see at this low power, nearly all the glomeruli are involved by the pathology as already shown. And I will go to high power. We can see the one glomeruli which shows marked mesangial expansion due to eosinophilic acellular amorphous material, which is weakly PAS positive. And in many glomeruli, this material causes near obliteration of capillary lumina, leading to global sclerosis. And the surrounding interstitium shows significant fibrosis with atrophic tubules, so which is more evident on this Mason trichome stain. So there is the significant HIFTA observed in the kidney biopsy. And further, and this material is orangophilic on Congo red stain. So we can see the orangophilic material in the mesangium of the glomeruli, occluding the capillary lumina and also in the both afferent and efferent arterioles, and which gives nice apple green birefringence on polarization, conforming to be the amyloid. And further, the fibrillary nature of amyloid is appreciated on this ultra thin section examination. And these fibrils are in the range of 9 to 12 nanometer, which is very typical of amyloidosis. And to subtype the amyloid, we first did the immunofluorescence. So we can see there is no restriction for kappa or lambda light chain. So it is not light chain related amyloidosis. And further, we went with the immunostain for the serum amyloid associated protein. So we can see this amyloid both in the glomeruli, afferent arteriole, and the artery shows the significant positivity, indicating SAA associated amyloidosis. So coming to the liver and kidney, so both the liver weighs 1100 grams and spleen weighs 320 grams. So both are enlarged. This is the cut surface of the spleen, and we felt that there is waxy feel on the cut surface. However, there is no focal or discrete lesions seen on this cut surface. And this is the represented microscopy. We can see the periarteriolar lymphoid sheath, arterioles, and sinusoids. We can see the lymphoid sheath is relatively sparse, but whereas the arterioles and the wall of sinusoid shows the amyloid deposition. And we can see there is the fusion of these amyloid depositions, creating the map-like appearance, the so-called Ladicious plane described in the literature. And this amyloid, here also we can see a nice apple green birefringence on Congo red stain. And further, this amyloid is positive for SAA immunostain. And here this is a section from the liver. We can see again the congophilic material in the central venule, the hepatic artery and portal vein. Here the amyloid is somehow the nodular appearance, where sinusoids are relatively sparse. And again we can see this apple green birefringence in the liver. Similarly, the sections from the small intestine shows the amyloid deposition in the arteries, arterioles, and the pancreas also shows the amyloid deposition, and the stomach also shows the amyloid deposition, whereas the section taken from the GE junction and the large intestine do not show any amyloid material. And the testis again shows the presence of amyloid in the arterioles. And the standard sections of the brain were examined. Both the meningeal vessels and the intracerebral artery were examined. There is no amyloid deposition noted. However, the pituitary, this is a section from the pituitary, we can see both acidophilic and basophilic cells. Here we can see the significant amyloid deposition in the arterioles and capillaries, which again is giving apple green birefringence. And the section from the lymph node again shows congophilic material, so amyloid both in the perinodal and intranodal arteries and arterioles. And the bone marrow, again, we can see the amyloid. So there is no doubt that this is SAA-associated amyloidosis involving extensively kidney, causing chronic kidney disease, and sinusoids of the spleen giving the Ladicious appearance, and hepatic artery, portal vein, and central venule of the liver, arterioles, and arteries of small intestine, stomach, testis, pituitary, lymph nodes, and bone marrow. So the next question again, so what causes the amyloidosis? So we'll start the lungs. So the both lung weighs 1100 grams. The pleural surface shows the fibrin tags. The cut surface of both the lungs are consolidated to feel. And apart from that, we can see that there is the discrete grayish white lesions present in all the lobes of both the lungs. And in addition, this is the apex of the upper lobe of the right lung. There is nodularity. On slicing, we can see there is grayish white lesion with cystic cavity formation. And further, we can see that the mucosal surface of trachea and major bronchi were unremarkable, and the lobar bronchi was also unremarkable. As we go down, the segmental bronchus and the further branches of the bronchus are markedly distended and dilated and prominent. We can see till up to the pleura. These changes are more evident in the lower lobe of the left lung and also right lung. The upper lobe of both the lungs is spared. And further, at this higher power, we can see that this branches, segmental bronchus, and the further branches of the bronchus, bronchioles, are significantly dilated with a thickened wall, and it is giving the appearance of the globular ballooning as described by the Reed in one of the famous articles of classification of bronchiectasis. And further, we can see on the slicing that there is some spongy appearance of the lung with tiny cystic spaces and also this type of dilated air sacs. So the many sections were taken from both the lower lobe and upper lobe of the lung, and this is the scanning microphotograph of one of the section of the lower lobe. So here we can see that, so these are the terminal bronchioles, also called membranous bronchioles. So I am saying bronchioles because there is no cartilage in the wall. And here we can see these are the lobules, okay, and separated by the thin fibrous septate. And further high power, we can see that both the bronchioles and the lobules are the markedly distended that we can appreciate at this low power. And we can see here the one lobule here. The one lobule contains nearly 6 to 7 acini. The 6 to 7 acini, we can see this one acini, this is another acini, this is another acini. So the acini starts from the respiratory bronchiole and it ends with the blind alveoli. We can see that there is the marked distension of the acini starting from the respiratory bronchiole till at the end. So this is so called the pan-acinar, the distension of the alveolar sac. And this pan-acinar is observed in the entire lobule. So we can say that there is pan-lobular, the dilatation of the alveolar sac. And this is a further high power. We can see that this alveolar duct and alveoli are markedly distended, and there is marked thinning of the interalveolar septa. And at many places, this interalveolar septa is fragmented and it is floating in the alveolar spaces. And there is also break observed in the interalveolar septa. So there is pan-lobular emphysematous changes observed in the sections taken from the lower lobe of the lung. And we can compare with this the section taken from the upper lobe of the same case. So how much this alveoli and alveolar sacs are distended, we can see that. And also we can see that there is marked thinning and the fragmentation of interalveolar septa. So there is no doubt that there is pan-lobular, also called pan-acinar emphysematic changes involving predominantly the lower lobes of both the lungs. And coming to the bronchioles, so here, this is the one of the bronchioles. We can see that, and it is markedly dilated, and it contains some secretions. The wall of the bronchiole shows some fibrosis and the moderate to marked lymphomononuclear inflammation. At this power, we can see that there is chronic inflammation and some fibrosis in the bronchial wall, and the lining shows significant mucinous metaplasia. And this is the sections taken from one of the segmental bronchus, the bronchus is not that much dilated, but there is marked thickening of the bronchial wall with increase in number of the mucous glands and the presence of chronic inflammatory cells. Also here we can appreciate that there is osseous metaplasia, so that indicates that there is chronic inflammation persist in the patient. And further, the Reed index was calculated. We know that that is the ratio of thickness from the mucosa to the cartilage to the thickness of the mucous gland. It was 0.7, so this definitely increased. And further, we can see that there is significant number of the mucous glands with some dilatation and the chronic inflammatory cells, and there is hypertrophy and hyperplasia of the smooth muscle. So there is also the additional component of chronic bronchitis present in the patient. And this is the sections taken from the upper lobe of the right lung. We can see the cystic cavity with the necrotic material and debris and the fibrosis in the wall. And the adjacent, the bronchioles and the alveoli shows the significant presence of neutrophils in the lumen. At many places, it breaks the wall, causing the abscess formation. We did the special stains, the AFB, the PAS, and gram stains and gram toad, but none of the special stains did not highlight any organisms in this cavity. The further, I submitted the sample to the microbiology department. The PCR for both 16S and 18S also performed, but both turned out to be negative. And there are the significant, the pulmonary hypertension changes were noted in the pre-acinar and interacinar, and also the pulmonary artery in form of the marked intimal thickening and medial hypertrophy. So in the lungs, so we have the pan-acinar or pan-lobular emphysema involving predominantly the lower lobes of both the lungs with, I have to say, the bronchial ectasia, and that is segmental bronchiectasis and chronic bronchitis and bronchopneumonia and pulmonary hypertension changes. So then what causes this emphysema and this bronchiectasis? So I will come back to the liver. So here we can see that the liver weighs 1900 grams, so it is slightly heavy. However, the capsular and cut surface do not show any focal lesions. Again, the cut surface has some greasy fill. Here we can see the gallbladder, nice gallbladder. So there is no atrophy of gallbladder. And pancreas, here we can see there is no cystic change in the pancreas. So the cystic fibrosis, although there are many different mutations, the cystic fibrosis is less likely in the patient. So here, this is the we can see the nice gallbladder, and the bile duct was also dissected, and it is unremarkable. And the many sections again taken. This is one of the sections. We can see that there is central venule, and that is maintained lobular architecture. There is not much disarray array of the hepatocytes, and the reticulin framework is maintained. And Mason's trichome, there is no portoportal or portocentral bridging fibrosis, so there is no chronicity in the liver. However, the many portal tract, apart from the amyloid, shows the significant mucinous metaplasia of the bile ducts. And this is another section. We can see that the mucinous metaplasia of the bile duct and the sparse lymphomononuclear cells in the portal tract. And the hepatic lobules shows that this type of microvesicles, this was prominent more in the periportal region. In addition to these microvesicle changes, we can start see this type of slightly basophilic material in the cytoplasm of hepatocytes. We can see here also. And further also here we can see this slightly basophilic to pale material in the cytoplasm of majority of the hepatocytes in the periportal regions, which on PA stain nicely highlights that these hyaline globules in the hepatocytes. This is the hyper, we can see this PS positive hyaline globules within the hepatocytes and also present in some Kupffer cells. So we have PS positive hyaline globules in the hepatocytes, which is dominant in the periportal regions. And further, we went with PAS with the diastase stains. The diastase is the enzyme which digests the glycogen. Okay? So here we can see that this hyaline globules still is positive for the PA stain even after treating with the diastase. And hyper, we can see all the glycogen in the hepatocytes are washed away, but these hyaline globules are retained after treating with the diastase. So this PAS positive, so just we can compare this slides. So this is just PAS and this is PAS with the diastase. So this PAS positive with the diastase resistant hyaline globules is the hallmark of alpha-1 antitrypsin deficiency. So as I already highlighted that this PS positive with diastase resistant hyaline globules is dominant in the periportal hepatocytes than in centrizonal hepatocytes. This is the another features typically described in alpha-1 antitrypsin deficiency. So we went with IHCs. I should agree that this antibody is already expired, it's a little bit old, but still we can appreciate these hyaline globules are highlighted on alpha-1 antitrypsin IHC on 1:200 dilutions. And further, here also we can appreciate. So the PS positive diastase resistant hyaline globules are also observed in the sections taken from the lungs in the type 2 pneumocytes and also in the macrophages. This is another section to show the PS positive diastase resistant hyaline globule in one of the pneumocytes. So coming to the heart, so the heart weighs 250 grams. The pericardial surface is unremarkable, and all the valves and all the chambers are unremarkable. But here also I found some mysterious and interesting finding that the most of the cardiac myocytes I can see, as we seen in the liver, we can see the similar slightly basophilic material in the myocardium. We can see here, and this material is also positive for PAS and resistant to diastase enzymes. So coming to the last, the lymph node, the significant number of lymph nodes are enlarged in this patient, including the thoracic and intra-abdominal lymph nodes. And here we can see one of the lymph nodes that both cortical and medullary sinus shows significant number of plasma cells and histiocytes, and many histiocytes shows the presence of hemophagocytosis. So I will come to my final autopsy diagnosis. This 29-year-old male with childhood onset bronchiectasis and chronic kidney disease. So we have PAS positive diastase resistant hyaline globules in the liver with mucinous metaplasia of the duct and pan-acinar panlobular emphysema involving the lower lobes of both the lungs with bronchiole ectasia and segmental bronchiectasis, chronic bronchitis and bronchopneumonia changes, and both these findings highly suggestive of alpha-1 trypsin deficiency. Although I couldn't able to perform the genetic studies, Dr. Amanjit ma'am also tried her best to get the primers, but still we didn't get the primers, but we will prove that. And that is SAA-associated amyloidosis involving kidneys, spleen, liver, small intestine, stomach, pancreas, testes, pituitary, lymph nodes, and bone marrow. And there is hemophagolymphohistiocytosis in the lymph node. So what is alpha-1 antitrypsin deficiency? So what is alpha-1 antitrypsin? So it is nothing but glycoprotein antiprotease. It is mainly synthesized by the hepatocytes, but it is also synthesized by intestinal and alveolar cells, neutrophils, macrophages, and cornea. But I reviewed most of the literatures. In none of the literatures, the heart is mentioned. But here I am finding this similar PS positive diastase resistance globules in the heart too. So nearly 80 to 85 alleles are described, and the severe deficiency allele is PIS allele, and it is followed by the rare CMO allele. And all these alleles do not affect the synthesis, but it causes misfolding and aggregation in the endoplasmic reticulum within the hepatocytes. And the few follow-up studies show that only the 2 to 2.5% of the patients develop chronic liver disease by 20 years and 5% by the 40 years of the age. So thank you very much.